Hello, everybody. Welcome to part two of a comprehensive review of PrEP. I'm Michael Saag from the University of Alabama at Birmingham, and our presenter today is Dr. Raphael Landovitz, Professor of Medicine, Director of the UCLA Center for Clinical AIDS Research and Education at the David Geffen School of Medicine. While we're talking, you'll see popped up on your screen a quiz or some polls that just please answer that for us as I move forward. That's important for us to understand who's there. Next slide. So we've already done a part one, as you can see, and that's available on demand at the IAS-USA website, which you can see here. But if you just type in www.iasusa.org, you can navigate yourself to this. But it was a very lively conversation, and we didn't want to rush it, so we went at a reasonable pace but didn't get to everything. So this is everything else, this particular webinar, so welcome. Glad you all can join us. Next. The IAS-USA has a board that you can see listed here, and some have conflicts of interest, a lot who do not, and that's also available on the website. Regarding today's presentation, Dr. Landovitz has been a consultant for Merck and for ViiV Healthcare. I do not have any financial conflicts. And prior to the event, the slides were reviewed by two unconflicted reviewers. For CME credit, we're going to go for about an hour and 15 minutes today. I'll intersperse questions as we go, so you'll get an opportunity to claim 1.25 CME credits from the Category 1 of ACCME, and then you can also get 1.25 ABIM maintenance of certification points. We also have available 1.25 nursing contact hours. We have pharmacy credit and pharmacotherapy credit available for all of you. These webinars are made possible through contributions from some of our pharmaceutical partners who provide funding but do not have any input as to the content or the slides regarding the activity. IAS-USA also obviously contributes to the activity. Next. So we're going to have poll questions as we go. That makes it dynamic. There'll also be some music playing from pretty much from Broadway. So those of you who are into that, you'll be able to kind of make your own personal guess as to what the show is. But the separate window, as you just saw, you can choose your response, and we'll display the responses after the poll closes. If you have questions, and I hope you do, you'll see at the bottom of the Zoom dashboard, there is a Q&A button with a little comment field with a question in it. That's where we want you to submit your questions. Please don't put that in the chat. I won't be looking for questions there. I'll be looking in the Q&A. And if you can, and you feel comfortable, please give your name and your institution, and we'll be able to personalize comments back to you. The chat is open that you can discuss comments with other attendees, but again, please submit your questions through the Q&A button. So we'd like to dedicate this series to the memory of our friend and colleague, Dr. Leticia Lopre. She was a faculty member here at UAB who died suddenly and unexpectedly at age 43. And it's a tragic loss, obviously, for all of us at UAB, but I think for the world and, of course, to her family. If you'd like to support her life and legacy, you can go to this GoFundMe link or use the QR code there. I know her family will appreciate that. She had two young kids aged about 8 and 4. Okay, and so now we'll stop sharing our slides and invite Dr. Landovitz to share his. And as we do that, we're looking at the poll results, and about 35% of us today are physicians. We have a number of nursing professionals and nurse practitioners, PAs, about 20% pharmacists, and then health educators and counselors. So welcome everybody. And now I'll turn over the program to Dr. Landovitz.
Thanks, Dr. Saag. Great to be here with you again. And thank you, everybody, for joining. Welcome back to everybody who joined us for the first part of this webinar, where we largely were talking about short-acting oral agents. We got to talk about a little bit about some of the long-acting injectable agents, but we didn't get to really get into a lot of the meat of some of the controversies around testing algorithms for long-acting injectable PrEP and how to handle confusing or discordant results in that context. And we really didn't get to talk about lenacapavir in any depth. And so we're going to do that today. And then some of you submitted complicated cases, and they're really great. And we're going to highlight two of them today, and we're going to talk about them. And the best thing about these is that we'll all have a chance to think about them together. Often, there aren't right answers. There are more right answers than one, and there are answers that I don't like quite as much, but we can talk about all that. And you all sent in a potpourri of really, really insightful and nuanced questions. And so we'll go over some of those too. So thanks to everybody who submitted cases and questions, and hopefully this is going to be really fun. Let me just, add further. I don't necessarily want to belabor this, but any of you who did know Dr. Letitia Allopre knew what a shining light and beacon she was for the future of HIV prevention research. She brought integrity, veracity, a commitment to equity and inclusion, and to shining a light on some of our most vulnerable people in Alabama and beyond. And her loss is so profound, I can't even begin to describe it. So again, as Mike said, if that GoFundMe is designed to support the college education of her kids, and if you're interested, please do contribute to that. I know many of us have already. Anyway, let's move on. These are my disclosures. These are our learning objectives. I'm not going to go over them in detail. I suspect many of you were on the first part of the webinar, so I'm not going to harp on this. Couple of quick poll questions, just to be so we know how many of you actually attended the first part of this webinar or watched it on demand. Please respond to this poll, and then we'll move on. Plus, it'll give you an opportunity to hear Dr. Saag's music choices, and nothing more fun than that.
A 2-year mission is our sacrifice. We are the army of the Church of Jesus Christ of Latter-day Saints. July 2, and today we'll know who will make the journey and where we'll go. We're fighting for a cause.
So I'm sure everybody immediately recognized that as of Book of Mormon. One of the most irreverent but hilarious musicals I've ever seen. Okay, so we have about 2/3 of people participated, just about 10% of people watched it on demand, and about 1/3 of people haven't. So, well, welcome to the people who were not part of part one as well. Okay, so since we're going to be focusing specifically and picking up where we left off about long-acting injectable PrEP and testing algorithms, let's start with this pre-test question. So which of the following is the optimal HIV testing algorithm for long-acting cabotegravir PrEP to monitor for breakthrough infections? And I'm going to be very careful here and say, according to the best available current data, because the guidelines are a little bit all over the place with this. So the intent of this question is say, are you up to date on the current, most recent thinking, even though guidelines may not have fully caught up? So for option A, rapid testing before starting, and then rapid testing at each injection, nothing else. Option B, viral load testing before starting and viral load testing only at each injection. Option C, viral load and an antigen antibody test before starting, and then only antigen antibody test in follow-up. And then finally, option D, antigen antibody testing before starting, and then both RNA and antigen antibody testing going forward to monitor for breakthrough. Please vote.
Son of raging love, the Jesus of suburbia, the power of love, gonna be our love, always standing, dying alone. Soda pop and Ritalin.
Okay. Mike, I have no idea what that was.
Well, that was from American Idiot, and those who are Green Day fans would know that even if they hadn't seen the Broadway show.
I did see the Broadway show, but I did not recognize it. That's embarrassing. I will tell you, Mike Saag, that it was at the St. James Theater in New York. But regardless, okay, so looks like 75% of you chose the answer that I would have chosen, which is that particularly in high incidence populations or anybody with a recent exposure in the last 3 to 4 weeks, I would do both an RNA and an antigen antibody test before starting, and only antigen antibody testing at the time of each injection following up. And we'll go over some of the data that supports that. Those are the guidelines that are in the IAS-USA guidelines that were in December 2024 in JAMA. The CDC guidelines have not yet caught up with that. And of course, we're not going to get political here, but anybody who's sort of following what's happening at the CDC, it's sort of unclear when/if we're going to see any updated guidance from the CDC going forward. So we're going to have to look elsewhere for prevention guidelines. Let's move on. Okay. Pretest question number 2. How often should patients who are administered lenacapavir every 6 months as a subcutaneous injection be monitored for breakthrough HIV infection? Option A, only before initiating len. Option B, before initiating len and every 6 months thereafter at the time of each subcutaneous injection. Option C, before initiating and every 3 months thereafter. And option D, test before initiating, every 6 months thereafter, and at the interval at which you might do sexually transmitted infection testing, otherwise between those periods. Please vote.
My sex change operation got botched. My guardian angel fell asleep on the watch. Now all I've got is a Bobby dog crotch. I've got an angry itch. Sex is fun.
Mike, I'm sensing feelings of anger coming through your choices
They are.
of songs at the moment. Okay. I actually don't know what that was either.
Well, that was from Hedwig and the Angry Inch.
There you go, which I actually saw at the Belasco Theater with Neil Patrick Harris a couple of years ago.
It was a great redo.
It was. Okay. So about 80% of you chose the answer that I like best, which is to test before initiating len every 6 months thereafter, and at the interval at which sexually transmitted infection testing is otherwise being conducted. And this is a little bit confusing if you look at the package insert that the FDA put out. That comes with lenacapavir as PrEP, which just to make sure everybody is also aware of this, there's a nuance here, right? This is the first time in the United States we're seeing an agent used for treatment and an agent used for PrEP having different brand names, right? And we don't like to use brand names here, so I hope Donna doesn't assassinate me, but I'm just trying to make the point that the brand name of lenacapavir when used for therapeutics, for treatment, is Sunlenca, right? But when it's used for PrEP, it's Yeztugo. And the reason that's important is the package inserts are different. the drug interactions and the contraindications for use are actually different. And there's additional considerations brought to bear in the prevention package insert. So Donna, I hope you're not going to kill me for using a brand name. I think that's an important distinguishing factor. Promise we'll refer to it only as Len going forward. But we'll talk more about this in a second. Okay, so let's go back to some cases. Let's talk about a case of CAB. And this is really designed to highlight what is currently in the CDC guidelines, and then what do you do if you get conflicting results and you're following the current CDC guidelines. So this is a patient who initiates PrEP with the oral lead-in, right, which is optional, with 30 milligrams of oral CAB every day, and tolerates it well without any sort of allergic signs or symptoms. And after 3 weeks of oral dosing, you start the injectable CAB. And you'll notice that this is after 3 weeks of oral dosing. And the reason for that is some people, and I happen to be one of those people, like to overlap the last week of oral PrEP, be it CAB as part of a lead-in, or if someone is transitioning from tenofovir-based oral PrEP with the first CAB injection. And that's because although we don't have good clinical data, the pharmacokinetics of a CAB injection suggests that 95% of people will have what we believe to be protective concentrations 5 to 7 days after that first injection. 50% of people will have it at 48 hours, but 95% of people will have those, again, anticipated protective concentrations in plasma between 5 and 7 days. So I like to overlap an oral regimen, if there is one, by about a week. And there's, let's see, some discomfort at the injection site, but it resolves within 2 to 3 days after each injection, which is fairly typical of people who do get mild to moderate injection site pain with these intramuscular gluteal injections. And again, the clinic that this patient is being seen in is following the current CDC and the FDA guidelines for monitoring for HIV infection with cabotegravir. And they are doing both an antigen antibody test and an RNA viral load test, both before starting CAB and at the time of each injection. And everything is going along swimmingly until the 7th injection, and everything had been on time prior to that 7th injection. And the 7th injection goes as planned, but the HIV testing that is drawn at the time of the injection, and appropriately, these tests are not awaited to be resulted before the injection is given. So the 7th injection has already been given, and the 4th generation test is negative. And the viral load, which is a quantitative viral load, is detected at 32 copies per milliliter. And I suspect many of you have been in this clinical situation, and it's terrifying, right? So you counsel the patient that a very sensitive HIV test looking at HIV genetic components in the blood has returned positive at a very low level. And out of an abundance of caution, one of my favorite phrases in the English language, you want the patient to come into the office as soon as possible to repeat the testing. In the meantime, because the status of HIV acquisition is unclear, you counsel the patient that they should use condoms for all penetrative sexual activity, given the uncertainty of the meaning of the test results, and you repeat the testing algorithm, and you get the following results. The 4th generation antigen antibody test is again negative, and the quantitative RNA at this point is not detected. So we have one where the only thing that's positive is the RNA at 32 copies per milliliter, and now the follow-up testing is not detected and nothing else is positive. And so the question for you all is, what is the correct interpretation of this series of results? A, the original result was a false positive. The follow-up testing confirms that there is no HIV infection. PrEP should be continued, and I will say without interruption or delay. B, the original results remain concerning for HIV infection, and a third round of testing using the same algorithm should be repeated in 2 weeks. Option C, the original results remain concerning for HIV infection. A third round of testing should be undertaken, and it should include a DNA assay, and that should all be within 2 weeks. And D, these results confirm HIV infection. Please vote.
What do you do with the BA in English? What is my life going to be? 4 years of college and plenty of...
Okay, that's obviously Avenue Q, one of the funniest send-ups of the Muppet Show I have ever seen. I laughed so hard I actually couldn't breathe. If you don't know the show, go find it. It's completely inappropriate, but so funny. Okay, so hey, this is great. We have some split answers here. About 40% of you said option A, the original result was a false positive, and this follow-up testing confirms that there is no HIV infection. And about another 40% of you said do a third round of testing and include a DNA all within 2 weeks. So, again, there's really no, perfect answer here, but let me tell you what the data suggest. Actually, we don't have more slides. We have another question. So let me discuss this first. So the HPTN 083, hold on answering that poll. That just popped up. We'll come back to that in a second. So the HPTN 083 data that we presented at the Munich AIDS conference in the summer of 24 and is currently under review at a popular journal that hopefully you'll be seeing it soon, suggests that if you have an isolated RNA positive result on CAB PrEP and you repeat it and it's entirely negative, that exonerates occult HIV infection. If you have an isolated RNA that's positive, again, that means all the other testing is negative. The only thing you have is the RNA, and the RNA is again detected at any quantitative level, including below the limit of quantification of the assay. So if you get a detected less than 20, for example, on that follow-up test, that counts. That actually has 100% positive predictive value of it being a true infection and this Levi phenomenon that we've talked about. Whether that's going to hold up in general clinical practice, I don't know, but that is what the available data says. So that's why I like option A as the best answer here. That's what the data says. Whether or not that's going to hold up with more general use on broader clinical assays that are quantitative RNAs, I don't know. I understand why people like option C, the idea of trying to do a DNA assay to, try and find evidence of integrated viral DNA that would have been reverse transcribed is an attractive concept. I will tell you, we've presented the 083 and 084 trial results, and DNA testing actually was not helpful in disambiguating true from false positive results when the only thing that was positive was an RNA prior. So I understand why it's attractive. It didn't perform super well in the clinical trials. So I don't know that would have been my go-to, but I understand why that would be a logical thing that some people would do.
So Raphael, we have a question about What do you do for testing up for long-actable injectables in low resource settings such as rural areas of Africa?
Yeah, and of course that question comes from our colleague Jason Hataye from NIAID. Hi, Jason, how are you? Jason and I trained in the same program a million years ago. So anyway, the answer is if you ask the WHO, you do your local Ministry of Health testing algorithm, which is really the only thing that's implementable in resource constrained settings. So that's what you do. Is that the optimal answer? I think balancing cost, feasibility, and public health benefit. Yeah, I do think that's the right answer. So in places where you can't follow a guideline that has more sensitive testing, I think you do the best you can, whether that's 2 rapids, or a rapid, and in some places an antigen antibody based assay. You follow your local testing algorithms at each before starting and at each injection time point.
And Ann Belay at the Community Health Center of Central Coast asked, what about testing algorithms for tenofovir-based oral therapy? Same?
Yeah. Thanks, Ann. This is actually a pet peeve of mine. I know the CDC guidelines suggest that we should be doing viral load testing to monitor tenofovir-based PrEP breakthrough also. And in fact, the reason it's a pet peeve of mine is they invoke the HPTN 083 data as supporting that recommendation. And the reason that's a pet peeve is, I think, again, full disclosure here, I'm biased. I led the HPTN 083 study, and that is not at all what the HPTN 083 study showed. So there is a small delay in assay reactivity with tenofovir-based PrEP. That's been known since 2014 when Deborah Donnell demonstrated that in the Partners PrEP study. But you are much more likely to be led astray, and you do not need RNA testing to monitor for tenofovir-based.
So do it the same way. And then any role for DNA testing? This is from Shannon at Five Horizons.
Yeah, I don't use DNA testing to assess for PrEP failure in any of these contexts.
Okay, so we're almost 30 minutes in. We'll pick up the pace and let's keep going.
Okay, that's Mike telling me not to be so verbose. Okay, great. Okay, so let's move on. Okay, so going forward, what is the recommended HIV testing algorithm for CAB PrEP failure? And we're going to be able to generalize this actually to Len, and we're going to come to this in a second. Okay, so the options are rapid diagnostic tests only, rapid diagnostic tests and viral loads, antigen antibody tests only, or rapids and an antigen antibody test. Yes.
Ragtime.
Yeah, that's Mike's favorite show. He can wax poetic about it for hours, but we don't have hours, so we'll talk about it another time. So I love this also. We've got a spread of answers. We have some people who, about 40% of people wanted rapids and a viral load to monitor for PrEP breakthrough. Some people wanted antigen antibodies only, and some people wanted rapids and an antigen antibody test. And honestly, there's a bunch of right answers here. I think the current IAS-USA guidelines recommend option D, that you do a rapid before you inject, and then you also do a laboratory-based antigen antibody test. I think a lot of people don't have the option of being able to do rapid tests in the clinic. They don't have that capacity unless they're sort of also a screening clinic. And so option C is also perfectly reasonable. The general approach that seems to be evolving for all forms of long-acting PrEP, and we'll talk about this again when we talk about Len, is that you do a viral load test and an antigen antibody test before you start, and then you do the best antigen antibody test you can going forward. And that seems to be where in resource-rich settings, consensus is heading for monitoring of all forms of long-acting PrEP. So no longer doing RNA or viral load testing in follow-up to monitor for PrEP failure unless there's a substantial delay between injections or signs or symptoms that might make you think about acute or primary HIV infection. Those are the contexts in which you still might want to do a viral load test. So let's move on and talk a little bit about why. So these are data from HPTN 083 and 084. 083 is the MSM trans women trial. It's on the left. 084 is on the right. And these are the performance characteristics of various HIV testing combinations. And this is positive predictive value. So what you can see here is both in 083 and 084, either two rapids or a rapid and an antigen antibody test performed really well in terms of positive predictive value in these two studies. So that is why the current IAS-USA guidelines also like a rapid and an antigen antibody test. But if you don't have the rapids, I think just doing an antigen antibody is reasonable. And again, in resource-limited settings, coming back to what Jason asked about, doing two rapids, which is a lot of resource, low and middle income country regular testing algorithms, did not perform horribly. What I want you to focus on, though, is this last line, and this is RNA testing. So when injections have been given on time, the positive predictive value of an isolated positive RNA test in 083 was less than 10%. And in 084, the women's trial, it was 25%. So let's think about that for a second. So you get an isolated positive result. In the individual assigned male at birth trial, 9 out of every 10 of those results was a false positive. In the women's trial, 3 out of every 4 of those results was a false positive. Now, you might say, well, so what? You're going to come back and confirm it. Well, number one, that has cost. Number two, what are the emotional and psychological traumas that having to give somebody a result that they might have acquired HIV infection, what is that going to do? And also, might it, depending on when the patient can come back into the clinic, actually delay subsequent PrEP administration? And is that going to then put somebody at risk and vulnerability? So I think the issue here is that is why it has come out of the evolving guidelines. So again, I want to refer you to the 2024 guidelines from IAS-USA that were in JAMA, and you can sort of find those recommendations. Again, Raj Gandhi was the first author there. So what about treatment of people who've broken through CAB? And, the question is, the observation that a lot of CAB PrEP failures have been associated with integrase resistance. And the big unanswered question in therapeutics is, can you treat these people with a dolutegravir or a bictegravir containing regimen? And what I'm showing you here are data from Urvi Parikh from University of Pittsburgh and Kate Koss from UCSF. And they presented a cohort of 7 individuals who are in a longitudinal study that they run called SeroPrep, and I'll tell you more about that in a little bit, where there were a series of people who broke through CAB PrEP with varying genotypic mutations. They were all treated with a protease inhibitor-based regimen up front, but 3 of the 4 of them were transitioned from a protease inhibitor-containing regimen to an integrase containing regimen, one BF-TAF, and then cabrilpivirine, and one to a doravirine containing regimen, and then cabrilpivirine. And they all did really well. So I think this certainly doesn't answer the question, but it certainly gives us confidence that even with these people with integrase mutations, certainly if you can get them to undetectable, you likely can then switch them to a dolutegravir or a bictegravir containing regimen. It does not answer the question about whether somebody right up front can be treated with a dolutegravir or bictegravir containing regimen at the time of breakthrough. But this is really reassuring. And obviously the group, I'm sure, is continuing to follow people and will have longer term follow-up of these individuals and likely additional individuals to share with us in the future. And I think this is an incredibly powerful data set, and we're really grateful that that they are monitoring this for us and can continue to inform this clinical question. We did actually present some similar data at CROI last year from HPTN 083, asking the question of, do we have any participants in 083 who had INSTI resistance when they broke through CAB PrEP, who were treated with an INSTI regimen up front? And the answer is we generally had good responses, whether people were treated with INSTI-containing regimens or PI-containing regimens. That's the other group. I will tell you there's one person who had an R263K mutation who was treated with an INSTI-based regimen who has suppressed. That's an N of 1. It doesn't mean you can do it. But clearly that is the most salient clinical question that people are asking with CAB PrEP failures, and we don't fully know the answer yet. My general approach at this point is still to upfront treat people with a protease inhibitor containing regimen, and then when they get to undetectable, consider switching them over to an integrase-based regimen. Mike, did you have some thoughts on that?
No, I think I would lean towards going to an INSTI regimen based on this, and you don't have a whole lot more to lose, and see what happens. We're at halfway point, Rafi.
Okay. In other words, keep moving. So just a little plug for SeroPrep. So again, SeroPrep is an NIH and CDC sponsored study run by Urvi and Kate. And if you have someone who acquires HIV in the setting of any PrEP, can be oral PrEP, can be any injectable PrEP, please consider reaching out to them. Their QR code and their number and their email are on this slide. It can be done entirely remotely. They can inform you about adherence. They can monitor people. And it's really, as you can see, informing the field in terms of understanding treatment response after. If you have a complicated clinical question, there's also at UCSF, the National Clinician Consultation Center. The number and the website are over here on the left side of the slide. You can get expert advice anytime, and they're always happy to help and are really expert. So that's a quick plug. Another quick plug is one thing that people have wondered in these long-acting PrEP breakthroughs. Often the viral load is extremely low. And so people have asked, what do we know about the HIV reservoir in that setting? Is it possible that the reservoir is really small, and they might be good cure study candidates, or might conventional ART actually result in a cure itself? And we don't know the answer, but there is a study. If you're near an ACTG site, there's a study called ACTG 5321, Group 6, that is looking at exactly this question. So you have someone who broke through CAB PrEP, and their viral load was never above 1,500, and you're near an ACTG site, please consider enrolling them. It's observational. We're just trying to assess the size of the reservoir. So stay tuned for more about that, because I think it's a really pressing question, a breakthrough PrEP of these long-acting agents. Okay, so next case, 42-year-old male professional presents for follow-up regarding HIV prevention. He's currently on CAB. And again, this not appropriate person-centered terminology. I don't like high-risk behaviors. My apologies. He has behaviors that are likely to expose him to HIV. including inconsistent condom use and multiple sexual partners. Recently, frequently international travel lasting up to 6 months has posed significant challenges for his adherence on Cabolet PrEP, frustration and anxiety regarding missed or delayed injections. Alternative options are of interest. What do you think he should do? Go back to daily oral PrEP, use on-demand PrEP, use daily PrEP with TAF FTC, start injectable lenacapavir, or something else? Please vote.
Whenever I see someone less fortunate than I, and let's face it, who isn't less fortunate than I, my tender heart tends to start to bleed. And when someone needs a makeover, I simply have to take over.
Okay, I mean, clearly people would be living under a rock if you did not know that that was from Wicked, Part 2, coming out at Thanksgiving. Very exciting. Okay, so most people, about 75%, wanted to go with injectable len. I mean, there's no real wrong answer here, right? The best PrEP is going to be the one that fits with his lifestyle. So I think you talk about options, but certainly, we're excited about the potential of len, right? And I don't think this is a surprise to anybody. Len is, was the Science magazine breakthrough of the year in 2024. It is now approved in the United States and pending approval in a number of other countries throughout the world. It's also approved. What country is that it's also approved in there? No, it's planned for submission there. Okay, so in Argentina and Peru and Mexico. Great. I think you're all aware of the Purpose 1 and Purpose 2 studies that led to the FDA approval of lenacapavir for PrEP in June of this year. These were randomized clinical trials that used a counterfactual background HIV incidence rate to evaluate the protective efficacy of len administered every 6 months. There are, of course, obligatory 2 daily doses that have to accompany initiation when you start lenacapavir. So you overlap the first injection on the day that the injection is given and the next day with 2 capsules of oral lenacapavir to get plasma concentrations up more quickly and get protective efficacy on board. And this was across populations for sexual exposure. So this included cisgender men, cisgender women, transgender men, transgender women, and non-binary individuals. And so we know efficacy across all of those. The primary results that were published in the New England Journal showed 0 infections in the cisgender women's trial and just 2 incident infections with a very low HIV incidence rate in the cisgender men, transgender men and women, and non-binary trial. There have been additional infections reported in the package insert at the time of FDA approval, and these protective efficacy estimates have not been updated based on those additional incident infections. But just be aware that there are no longer 0 HIV infections in the Purpose 1 trial. We have not seen public presentations of either of those new buckets of small numbers of infections, and we look forward to learning more about them. So again, these are the primary results that were published. 100% efficacy compared with this counterfactual background in cisgender women, 96% efficacy compared with the counterfactual background in the cisgender men, transgender persons, and non-binary trial, all tremendously exciting results. The other thing I want to point out is that's an every 6-month subcutaneous injection. Gilead, the company that makes lenacapavir, actually already has a brand new formulation of lenacapavir that's going to be a once yearly intramuscular injection. Actually, it's a pair of intramuscular injections. And that is, it's either just opened its phase 3 bioequivalence trial or is about to open. I'm not sure if it's officially opened yet, but if it isn't, it's about to. And obviously that could be tremendously exciting as well, depending on the results and if people tolerate an intramuscular injection. In terms of recommendations for lenacapavir and its testing, right? The CDC, I know, is fervently working on some guidelines, but they have not come out yet, and it's sort of unclear when they will come out. So the only guidelines that are available at the moment are from a letter from IAS-USA that was published in JAMA at the beginning of July. And again, it sort of reflects what we have been talking about, that really, if there's a high incidence population or a likely exposure in the last 3 to 4 weeks, you would do an RNA as well as an antigen antibody test, a laboratory-based test, before starting. And then in follow-up, you would just do a laboratory-based antigen antibody test, added every 6-month interval. And again, here is the recommendation that if you are already bringing someone in for more frequent STI testing anyway, also do HIV testing at those time points. So I hope that's clear that where that comes from. Happy to answer any questions about that, but we're now going to go in our last half hour together into your questions and cases that you submitted. So, couple of lenacapavir focused questions. Couple of people said primer on lenacapavir. Happy to answer any specific questions, but I think we've talked a little bit about len and the nuances of the testing. If people have other questions, please feel free to ask them in the Q&A directly, and we can talk about them. Somebody wanted counseling considerations specifically for patients starting lenacapavir, and I'd be happy to talk about them, but we need to know specifically what people were wondering about. Are people wondering about injection site reactions? Are people wondering about efficacy? Are people wondering about resistance? All of those things would be things that you would want to entertain in a conversation with somebody who's starting any PrEP agent. And of course, we have an evolving and increasing understanding about how to work with len, including all of the complexity of the insurance approvals, which we're just beginning to learn about as it has become, since July, available in our commercial pharmacies. And you all probably have a lot of experience already with that if you've prescribed it. And I think any experience with the complexities around getting insurance approvals and delivery probably would be useful to this group if people want to share that in the Q&A, and we can talk about it. So people wanted to know about understanding the lenacapavir tail, and the answer is nobody really understands it. But what I will tell you is what we've learned from cabotegravir is that it's a very sharp drop-off between protective efficacy and zero efficacy. And you need a longer drop-off if you're going to select for resistance, right? Because you only get resistance when you have viral replication in the presence of drug. So we're going to learn about this. The lion's share of the small number of incident cases that we've heard about to date in lenacapavir have all had len resistance. So you wouldn't want to use len as part of a treatment regimen when you break through on len. Again, we have not seen public presentation of this, but in the package insert for len for PrEP, there is a description of one case that occurred during the len tail. And we don't know about the resistance to len in that context. So I think it's a story that's evolving. But the good news is, because currently len is not part of our first-line treatment regimens, the idea of generation of resistance is not one of immediate concern relative to the choice of a first antiretroviral regimen. So I have asked our colleagues at Gilead about the duration of the tail, and I've not gotten sort of a quantitative answer. And my interpretation of that is it's quite long, and we don't fully know the answer and the dispersion of that tale to date. If anyone has heard of any data on that, we'd love to hear it. I have not. In terms of transitioning from injectable cabotegravir to injectable len, I mean, I think about these sort of very similarly, right? So we believe that injectable cab is best administered at 8-week intervals, right? So if you're going to start any other PrEP agent, you'd want to start it certainly not later than 8 weeks after the last cabotegravir injection, assuming that it wasn't what they didn't just get a single cabotegravir injection, right? Because the first 2 cab injections are still separated by 4 weeks, and then you go to 8-week intervals thereafter. But once you've gotten past that second injection, 8 weeks later, you would be due for another injection. Now, if you're going to say, well, we might believe that len takes a couple of days to get prophylactic efficacy, might you want to start it at week 7 after that cabotegravir injection? Yeah, maybe. There's no hard and fast rule here. What I have heard, again, this is based on PK data and modeled protective efficacy, is that 48 hours after the second oral dose of len, you can be expected to have protective serum concentrations. So if you think about that day, the second day after the first len injection, is when that second oral dose is taken. It would be about day 4 of the injection cycle. So starting it perhaps somewhere between week 7 and 8 of the cabotegravir injection cycle might make sense. Again, there is no formal guidelines about overlapping of these agents. So this is very much style and art and less about science. So I think it makes sense to do if you can plan for it. Is obligatory? No. But that is how I approach it. And those are my thoughts on that question. Okay. Mike, I know there's some questions coming in. Anything you wanted to
Some
stop
of
us and
them were,
address?
yeah, I think people can read these online themselves. There's from one of the Gilead scientists, they give a description of some common sense approaches to how to think about lenacapavir after you stop, and that it can last for 12 months or longer. I think the main thing, and Kevin Carmichael wrote in to sort of talk about the potential drug-drug interactions, and it's mostly out of a concern for moderate inhibition of CYP3A4. That's the one we're all familiar with, for example, cobicistat and ritonavir, not nearly as potent of an inhibitor, but it does have some activity. And I think if there are any questions, you could go to the Liverpool drug interaction site and get some guidance there.
Yeah, no, I agree, Mike. The drug-drug interactions are a little bit complicated. And Kevin, thanks for bringing that up. In the len prevention package insert, rather than some prohibitions against co-administration, which exist in the len for treatment package insert, there are some recommended dose modifications to len for PrEP. And I'll be honest, they're a little complicated, so I'm not going to try and get into them on this webinar because I think they're a little bit beyond the scope. But when you are prescribing len for PrEP, a careful review of medications, of concomitant medications someone's on, is really important, and make sure there isn't something that is going to have that interaction, rifamycin, some of the anti-seizure medications in particular. So please do take a look at that. There's a lot of detail and some very helpful tables in that package insert. Okay, so there were a lot of questions that people submitted about insurance, payment, and access. I think it's a little bit beyond what we're going to have time to talk about today. And as I alluded to earlier, I really would look to you all if you have had challenges or experience with the prior approval process, with any challenges, because what I have heard, and again, I have not experienced this myself yet, that sometimes a separate prior authorization may be required to get the oral loading doses of lenacapavir in addition to a prior authorization approval for the injectable product, and coordinating those prior authorizations and then coordinating the oral dosing, which is coming from any commercial pharmacy with the administration of the injectable dosing has sometimes been challenging. But I think we're very much in the early phases of understanding both the best practices, challenges, opportunities for implementation here. So if any of you have experience, please do share it. We did get a question last time about whether you could either skip the oral lead-in or use a different agent to sort of buffer that time to protection. And the short answer is those are not recommended ways to do this. So those cannot be recommended. They haven't been studied. Not a good idea. Would not do that. In theory, might it work? Sure, but we do not know anything about the parameters, and you'd be sort of flying in a very, very data-free zone. So someone asked about PrEP use trends and what we know about it. These are the most recent data from the CDC, and this was published in JAMA last year. These are 2023 data. And the thing that I would just point out to people is what's in orange here. You know, the others are various oral PrEP options and their number of persons taking it. And, you know, we've been very slow to adopt injectable PrEP in the United States. And I think, you know, all of you know quite well what the reason for this is operationally it's complex, the approvals are complex, and it's really involved an entirely new clinic workflow that we're still trying to figure out. So we're obviously going to keep close tabs on this as well as len use, but we don't have those data yet. I'm not sure if any of our colleagues who are online have any initial data on numbers of prescriptions that have been written already, but I've not seen any public data that have quantified what the uptake has been in the short time since approval. But long story short, you know, we are seeing increasing rates of new starts of oral PrEP, but not so much injectable PrEP yet. So laboratory monitoring and diagnostic challenges. So a lot of questions about this. Somebody said, you know, what do you do if you find incident LFT abnormalities? And they didn't specify what kind of PrEP we're talking about here, because no baseline LFTs are recommended as part of monitoring. And that's why, even though it's not part of any of the guidelines, I do like to get a baseline set of liver function tests before starting, because how else are you going to know to monitor, for example, for incident Hep C or assess for a toxicity? You know, how often you would use you would monitor for it? Basically, going to be on symptoms or signs or other clinical provocateurs that tell you. But when I'm starting somebody on a new medication, I often will send a baseline set of LFTs, a CBC, and a creatinine, but again, those aren't part of guidelines. Use of RNA testing in addition to antigen antibody testing for monitoring of patients on len. So the FDA guidance that's in the package insert, and I showed you the IAS-USA guidelines also that concur with this, before starting only, not as part of monitoring, at least for on-time injections. And for len, an on-time injection is defined as within 2 weeks of the 26-week interval. So if it's longer than 28, maybe you would want to repeat that RNA testing that you had done before starting, certainly if there had been exposures or any symptoms that are concerning for acute or primary HIV infection, but not routinely otherwise. Who should receive RNA testing with oral PrEP labs? Again, you know, the CDC says do it before starting and in follow-up. I have never done it in follow-up. Don Smith, the late, great former director of HIV prevention at CDC, and I had some heated words about that recommendation. I've never agreed with it, but it still stands as part of the CDC guidelines. I think it makes sense to do before starting if there's a recent exposure or in a high incidence population or after a delay. And with oral PrEP, I think a delay is probably on the order of 2 weeks. So if somebody's been off it for 2 weeks and you're restarting, I think it probably makes sense to do. Otherwise, I do not do RNA testing for oral PrEP for monitoring of breakthrough. Diagnostic dilemmas, suspected PrEP breakthrough with undetectable viral load. We'll do some exciting cases. So we have 15 minutes to get to some exciting cases that show us exactly that. Okay. Questions about guidelines and testing. So perspectives on the new British PrEP guidelines. I'm not exactly sure what the person who asked this was referring to. The one thing that is notably different about the British PrEP guidelines is they do recommend an on-demand TDF FTC dosing schedule for vaginal exposures. They recommend 2+7, so a double dose and then 7 daily doses thereafter for on-demand. To me, that sort of becomes daily dosing immediately, and I don't know what that's based on. But Mackenzie Cottrell at University of North Carolina did some really elegant pharmacokinetic modeling that suggests that rather than 2-1-1, 2-1-1-1, so 4 doses in that pattern for vaginal exposures would be expected to work. We do not have any current guidelines that actually recommend that in the US. But do I think that it's reasonable if you have somebody who won't take PrEP any other way? Yes, I think it's better than nothing. Recommendations for quarterly STI testing for patients on 6-month HIV PrEP therapy, individualized or universal. My recommendation and what we have in the IAS-USA guidelines that I mentioned were published in a letter in July. It's by population. If the population that the individual represents in terms of exposure category, you would otherwise test them for STIs every 3 months, then I would do that. I think that interrupting the STI transmission cycle is really important, an important component of PrEP. And I would not space it out further otherwise. Plus, if somebody's on doxypep, which many of these individuals are, you probably want to be testing them every 3 months anyway. Question about authorized age for PrEP. There is no floor on age. It's a weight-based floor. So 35 kilograms or 77 pounds, and that's for all the currently FDA-approved PrEP agents. So no age floor, just weight. Hope that all makes sense. Okay. HIV PrEP injectables as an option for persons who inject drugs. So we don't have any efficacy data for any of the agents, yet. There are a number of demonstration projects that are designed to help inform this, but they're really not going to demonstrate an efficacy result. But remember that persons who inject drugs have sex too. So I think it is a reasonable thing to do to consider sexual protection data as sufficient to recommend a PrEP agent if you have someone who is sexually active and injecting drugs, even though there aren't data specifically around parenteral exposures only, because most of the time that doesn't happen in a vacuum. So PrEP injectables as an option for cisgender women, absolutely 100%. Both of them have outstanding data in cisgender women. Delayed optimal efficacy of PrEP before and after exposure, oral versus parenteral. Starting after is dicey, right? That's PEP. It's a sooner the better. Animal models say, really within 8 hours. If you're doing it before, right, with tenofovir-based PrEP or CAB, again, we're estimating, I like to say 7 days, unless you did a double dose of TDF to start the tenofovir-based PrEP regimen, or you use the oral CAB lead-in. And Len, as I mentioned, what we believe to be the case is 48 hours after the second oral dose, so day 4 of the injection. And then a question about most common and most serious side effects of oral and parenteral PrEP. This is being incredibly reductive, but to me, the oral PrEP options, GI distress is most common, and both the injectables, they're injection-related side effects that are the most common ones that we hear about. Okay. Mike, any questions before we go into these cases?
One regarding the concern about if you inject and didn't have an oral lead-in, you might have a long allergic reaction if there is one, and that's one of the reasons why some folks like to do an oral lead-in. And then the question just briefly, I think we can go on, but about a 13-year-old getting PrEP without parental consent, that's going to be individual based on where you live, more or less.
Yeah, and some states consider it part of STI services and can be done without parental consent, and in some states you can't do that. And that's incredible.
Let's get to the case.
Okay, so this is a great case that one of you sent in. Thank you. So an HIV seronegative individual in a committed relationship with a partner with known HIV, and the partner has significant challenges to ART adherence, complicated by ongoing methamphetamine use by both individuals. The seronegative partner currently receiving CAB for PrEP. The partner who has HIV, who also receives care in the same clinic, has documented resistance mutations, including Q148H and E138Q in the integrase gene, as well as reverse transcriptase M184V. So known integrase resistance, known M184V in the partner. Person is on CAB PrEP. Would you change the PrEP regimen if the PrEP user's main partner had known resistance to the agent? Option A, yes, for sure. B, yes, if it was CAB that they were taking, but not if it was tenofovir-based PrEP or LEN. C, yes, if it was LEN, but not tenofovir-based PrEP or CAB. And D, I definitely would not change. Please vote.
It's the capital city of the USA.
It's not.
The city I swore I'd see for myself one day.
But you've actually been in New York before.
Yes. No. But I've seen Home Alone 2 quite a few times.
Are you serious?
Okay, so we only have 5 minutes left, but I have to tell you, that is from Two Strangers Carry a Cake Across New York, a musical coming to Broadway this fall. Go see it. You're welcome. Okay, there's no right answer here. There's art. This is art, right? I mean, one thing that I would consider is, is the person on ART viremic consistently, right? Because that's going to impact their transmissibility. Are there other partners that are part of this relationship, or is this a monogamous dyadal partnership? And nobody knows the right answer to this. I would have anxiety about leaving somebody on CAB PrEP who had integrase resistance in a viremic partner. I don't think that would be my choice. Given everything we know here, I would probably go with LEN. And the reason I'm saying that is probably because tenofovir-based PrEP, even though it will still have some activity, right? M184V reduces the potency of the FTC. It doesn't completely abrogate it, but it also increases the susceptibility to tenofovir. We have seen seroconversions in the context of M184V transmitted virus on tenofovir-based PrEP. Macaque models suggest that there should be substantial activity, but I think it generally makes sense to make sure that the individual that you're trying to prevent from acquiring HIV is not knowingly being exposed to virus that is resistant to the agent that they're taking. I think that's a sensible approach. We don't have clinical data that support one way or the other. So that's my take on that. If people have other thoughts on it, would love to hear. And then in our last 5 minutes together, love this case. Whoever sent this in, thank you. I know we asked you 17 billion questions in response, but that's because the devil is in the details. And this is a complicated cabotegravir testing case, and it's an is it or isn't it situation. And, I don't think we really know the answer here, but this is a 41-year-old male who initiated long-acting CAB with no prior history of PrEP use before they started CAB, and they did direct to inject. So there were no oral CAB lead-in used in this case. So about 6 days before the first CAB injection, we have some HIV testing results here, right? We have a 4th gen that was reactive, but the confirmatory testing was negative. So this was interpreted as a false positive, so negative 4th gen test, and a qualitative RNA test. So a qual viral load was negative. Okay, that's 6 days before starting. The day of the injection, the first injection, another qual test is done and it's negative. Okay, so it does not seem like we're brewing HIV in between these testing events. And then at the day of the second injection, a month after the first, we have testing where, again, the 4th gen is reactive, but now the confirmatory seems to be evolving a little bit. The IFA for HIV-1 is indeterminate, and the HIV-2 is non-reactive. Again, the qual RNA is non-reactive still, and a Western blot is done. It's kind of hard to get a Western blot in 2025. Kudos to this team for getting a Western blot. Whoops, what just happened? We went forward. Hold please, let me try and go backwards. Okay, sorry about that. It was a weekly positive P24. And then they brought the individual back in 30 days later. The injection had already been given, so nothing else could have been done. And the 4th gen was reactive. The IFA had evolved further and is now reactive. The RNA is still non-reactive. And not only is the P24 positive, but the GP41 band on the Western blot is positive. So that's the story. So my question to you, and this I promise is, oh, nope, sorry, you don't get a question. I lied. You can put your thoughts in the Q&A. Is he or isn't he? And, we don't, full disclosure, we don't have an answer to this question. It certainly is a very provocative case, right? This person clearly has something that is causing false positive antibody responses, and that pre-existed them starting on cabotegravir, right? The 4th gen was positive before we ever started. And now we're getting some IFA and some Western blot evolution that either means there's virus exposure or someone's having some sort of polyclonal B-cell activation that's generating all sorts of antibodies. And we had asked about, there was a prior history of syphilis that was treated. This is not somebody who's pregnant. There were some recent vaccinations that may have confounded this. There's no known like lymphoproliferative disorder or pre-leukemic state or autoimmune situation going on here. So it's unclear, but my spidey sense is that this probably is not true HIV infection. But you can understand the anxiety of the team here because you have a fourth gen test that is positive and fully evolved, and you have a Western blot that now is being called positive as well. The one thing I would point out is that the Western blot is a really insensitive test, and you would expect an RNA to be positive before a Western blot would be positive, right? Everything we know about breakthrough in these long-acting injectable situations suggests there's going to be viremia that is going to generate an antibody response, and we've never seen viremia. One question we did ask the team that I don't know that we ever got a response to is, I'm not sure what qualitative viral load assay this is, and every viral load assay, even if it's qualitative, has a limit of detection, right? So if the limit of detection of this qualitative assay is 50, maybe they're viremic at 20. And maybe if we did a quantitative viral load, we would have caught it. But most of these qual RNAs, the limit of detection is low. It's you sort of between 12 and 30, depending on which assay we're talking about. So I don't know that, but it does beg the question. If you all have thoughts or additional questions about it, would love to hear them. Somebody's wondering if they could be an elite controller who's actually infected. Certainly possible, right? And they would have been, could they have been positive all along? But then why wasn't their initial IFAs, positive early on? So you'd be implying, that was acquired through CAB and now be an elite controller without ever manifesting viremia. So I just don't know. It's probably somewhere on the list of possibilities, but seems unlikely to me.
So when I was a fellow in the 80s, HIV testing for antibody just came out in May of 1985, and we discovered a false positive Western blot and reported it, and it was associated with an anti-mitochondrial antibody. So I'm skeptical as well. And I think a quantitative HIV RNA would be the next test. And if it's negative persistently, I think I'd just continue on, just like we talked about earlier. Okay, so we should go to the post-test questions here. Thank you, Rafi.
Yep, so here we go. Post-test question number 1.
Yeah,
Which of the following is that? So this is
Yep.
about the optimal testing algorithm for CAB-LA PrEP. I'm not going to read them in the interest of time, but please vote.
Well, dance 10 looks 3, and I'm still on unemployment, dancing for my own enjoyment. That ain't it, kid. That ain't it, kid.
Thanks, Mike, for stopping that before it became rated R. That's a chorus line, which recently celebrated its 50th anniversary. Let's see people's results here. Okay, 80%. Let's see, answered option C. Let's see, for breakthrough infections, yes. Excellent. Good job. We did some education there. That is great. And let's see, I think we have one more post-test question. Here we go. How often should patients who are administered LEN every 6 months be monitored for breakthrough infection? Please vote. Last time, I promise.
What's that coming up the Silk Road out of China? The Black Death, woo! What's that creeping around your pee-pee?
Another classic. It's called Something Rotten. Also excellent. Go see it if you have the chance. Not playing anymore, but also at the St. James Theater in New York, like American Idiot was. Thank you, Mike, for that. So let's see what people said. Yes. Okay. So excellent. Almost 90% of you got what I think is the right answer. So excellent. We've done some good learning here all together. All right. Well, thank you all for sticking with us for this 75-minute part 2. I'm going to turn it back over to Mike to close us out. Thank you for the great questions and the interaction.
Great. We have a couple of closing slides. Rafi, need you to stop sharing, and we'll bring up the other set of slides real quick. All right, so evaluations on how to claim CME will be emailed by 5 p.m. today or tomorrow, 5 p.m. Pacific time. Please fill out the reviews. That's very important to us so we can continue to have these educational programs up to date. If you're not receiving emails in general from IAS-USA, you can request that on the IAS-USA website. Next. Okay, and remember that part one, which is on the website now, it's available on demand and you can get CME for that as well. There's updated drug resistance mutations. Fortunately, we don't need to use these as much anymore, but when we do, this is extraordinarily helpful. And this is the antiretroviral therapy resistance panel, and it's in the topics of HIV medicine. There's a podcast that I've been running on behalf of the IAS-USA called Going Antiviral. I encourage you to visit. Just this week, we released a podcast with Darcy Wooten from Washington University on navigating care with GLP-1 receptor agonists. She's very well versed, great educator, a good podcast. Coming up, we have an update on hepatitis B cure and a webinar with David Wiles and Deepika Bhattacharya. Coming up as well for people who are new to the field. So if you have colleagues who are just starting in HIV, especially new physicians or advanced practice providers, this will be a great place to come and hear about just the basics on pathogenesis, antiretroviral therapy, and primary care issues in HIV. And then something different, remember it's the Antiviral Society USA, IAS-USA, on bacteriophages, how to use viruses to treat bacterial infections. So if you have interest in that, there's a 2-day conference in Washington, D.C. coming up in October. And in November, there's a in-person symposia in Chicago at the David Rubenstein Forum at the University of Chicago. And you can see the faculty listed here. That promises to be a very exciting opportunity to not only go see the talks, but to interact with colleagues, which we don't get to do quite as much, obviously, on webinars. Okay. And I think that's it. So thank you again for participating. This has been, again, a wonderful webinar. Thank you, Dr. Landovitz, for your very comprehensive approach to providing this information. And we will sign off at this point. Thank you. All right, I assume we're no longer broadcasting.